the topic of my case is red flags for malignancy in dermatomyositis. So I'm presenting a case of 51-year-old female who presented with complaints of generalized rash for 2 weeks and abdominal pain for 1 week. So she was well before 2 weeks when she started developing rash over face, knuckle, anterior chest, elbows, and thighs. The rash was painless, non-pruritic, and it was reddish in discoloration. And it was then gradually it became more erythematous and confluent. She also experienced continuous dull aching abdominal pain for last 1 week. This was associated with early satiety and reduced appetite. There is no complaint of oral ulcers, joint pains, fevers, or excessive hair fall or sicca symptoms. There is no complaint of myalgias or muscle weakness. There is no complaint of dry cough or shortness of breath. And there is no history suggestive of Raynaud's phenomenon, puffy finger, or skin tightening. And the past history and family history is not significant. So examination, her vitals were normal. Her BMI was in overweight range, and there were no evidence of pallor, icterus, clubbing sigma. And these are some photos of a rash. As you can see that there is erythematous discoloration of the skin over the knuckles, which is equivalent to Gotran's papule. And if you see closely, there is periangular erythema as well. And there is erythema over the elbow joint as well, with some scaling of the overlying skin. So this is Gotran's sign. And in the next image, we can see that there is facial erythema. Again, there is some some scaling of the skin over the forehead. And we can see that there is a rash on the lateral aspect of upper thigh as well. And there is significant scaling in it. So this is Holster sign. But what I would like to highlight is that there is significant amount of scaling. So through this rash, it was quite clear that the rash is consistent with cutaneous dermatomyositis. So her systemic examination was normal. So talking about the muscle power, her muscle power was as good as normal. So muscles were not involved at this point of time, and her MMT score was 148. Talking about the cutaneous involvement, her CDASI score was predominantly there was activity. The score was 28, and there was damage also because of hyperpigmentation over the lateral aspect of thigh. So one single investigation which would confirm the diagnosis and a simple bedside tool is nail fold capillaroscopy. So we can see that we could find out giant capillaries in her case. So this confirms the diagnosis of cutaneous dermatomyositis. And these are the labs of this patient. As you can see that SGOT is slightly higher than SGBT and there is LDH is slightly elevated. So this suggests some amount of muscle involvement. Although there is clinically she was amyopathic. CPK was within normal range, and ANA by immunofluorescence showed a nuclear speckled pattern in high dilution and high titer. Her acute phase reactants were raised. However, a more serious diagnosis unveiled when her further scans were done because of dull aching abdominal pain. So an ultrasound revealed a heteroechoic lesion in left lobe of liver, which was suspicious of malignancy. So a triphasic CT was done, which again showed the multifocal hepatocellular carcinoma with tumor thrombus in left portal vein. Her alpha fetoprotein was raised, and the liver biopsy confirmed the diagnosis of hepatocellular carcinoma. We got a PET CT scan done to look for the extent of the malignancy, and we had found she had metastatic abdominal lymphadenopathy. So at this point, we were awaiting her muscle myositis antibody, and because we already knew that the patient had malignancy. So the thing that I had highlighted, the rash was predominantly scaly. So this underlying associated malignancy and scaly rash is consistent with an antibody known as TIF1 gamma. So her TIF1 gamma was positive, and there was also positivity of Rho52. Rho52, we know that it can coexist with myositis antibodies, predominantly with anti-synthetase antibodies, but in our case, it was also positive with TIF1 gamma. So our final diagnosis was metastatic hepatocellular carcinoma with paraneoplastic cutaneous dermatomyositis. I would like to highlight that at this point of time, patient had no muscle involvement. So she was started on treatment for hepatocellular carcinoma, and for dermatomyositis, because she had only cutaneous involvement, we gave mild agents like hydroxychloroquine and topical steroids. However, after 2 months later, she presented with frank myositis. So she presented to OPD with complaint of weakness of all four limbs for last 2 weeks, and it was associated with difficulty in standing up from sitting or squatting position. There was difficulty in combing hair and raising arms, and she had difficulty in getting up from bed, for which she needed support. And along with this, she had bulbar muscle involvement also. She had difficulty in swallowing foods. The difficulty was more to solids than liquids, and it was associated with nasal regurgitation of feeds. The family also noticed that there is the change in the tone of her speech. So there was a nasal twang in her speech, and she also complained of ulcers in mouth over the palate, which were painless. Along with that, she had blackish discoloration of the skin over tips of right index and middle finger and right calf. So I would like to share the photos. So this is the ulcer she was talking about. So there is, as you can see, that there is a patch on the hard palate, which is ovoid in shape, and it is surrounded by an erythematous border. So this is an ovoidal palatal patch, which is seen with Tiffin gamma. And as we can see that there is cutaneous necrosis over involving the skin over the fingers of the uh, palmar aspect of the fingers and over the calf. So there is cutaneous necrosis and ovoidal palatal patch. Now, our patient already had a malignancy, but for example, when a patient of dermatomyositis presents with these two rashes, we should be alarmed, and because these are the ominous signs of malignancy. So whenever we find this kind of these signs in a patient of dermatomyositis, we should cautiously look for malignancy. In our case, the malignancy was already known. So and this time she had severe muscle involvement, and then her MMT score has dropped to 110. However, there was some improvement in the cutaneous disease, and CPK continued to be normal. We did a MRI myositis screening for this patient because the CPK was normal and patient had clinical muscle weakness. And this is what we found. So as we can see that there is diffuse myoedema and myofascial edema in all the muscles. So proximal and distal muscles both are involved in both upper and lower limbs. So we did a repeat PET-CT scan. The oncology team did a repeat PET-CT scan which showed progression of metastatic disease, and she had to be put on second line chemotherapy. Because of the severe weakness, we started her on IV methylprednisolone and IVIG therapy. However, she did not show much improvement, and she succumbed to her illness 2 weeks after discharge. Probably she had some aspiration pneumonia to which she succumbed. So with this, I would like to talk more about malignancy in dermatomyositis. So this is an excellent paper which talks about risk factors in of cancer in myositis and how do we screen for it. So talking about the serological risk factor, TIF1 gamma and NXP2 we know are associated with malignancy more often than not. So these are high risk antibodies, and SAE, HMGCR, and autoantibody negative myositis is associated with intermediate risk, and rest of the antibodies have lower risk. So this was about the serological risk. Now talking about the clinical risk factors. So older age at onset, male sex, dysphagia, cutaneous necrosis, rapid onset of myositis, refractory myositis, and elevated inflammatory markers, raised CPK are the clinical risk factors. So our patient had many of these clinical risk factors. And talking about the protective factors, arthritis, ILD, and Raynaud's. These are the protective factors against malignancy. And our patient had none of the protective factors. So how does a TIF1 gamma actually lead to malignancy? When we when we logically speaking, basically this anti-TIF1 gamma are defense mechanism of the body. So TIF1 gamma regulates TGF beta pathway. Whenever there is mutation in TIF1 gamma, that leads to aberrant TGF beta activation and formation of cancer. Now, body develops an immune mechanism against this aberrant TIF1 gamma. And as a part of collateral damage, the keratinocytes and myocytes, which also contain TIF1 gamma, are damaged by the immune system, which manifests as cutaneous dermatomyositis. Whereas the main purpose of this antibody is to destroy the cancer. So TIF1 gamma are associated with malignancy, but they are basically a defense mechanism against this cancer. So depending whether the cancer cells are more or whether the immune cells are more, there will be either tumor elimination or there will be either tumor progression. But in all cases, the muscle has to bear the collateral damage. So myositis will be seen in all cases. So TIF1 gamma is a risk factor, but actually these antibodies are meant to protect from cancer whenever there is a cancer. So ovoidal palatal patch has been described by multiple names like ominous signs and potentious sign. So they have shown that this is more often whenever in a patient of TIF1 gamma we see a ovoidal palatal patch, it is more often than not associated with malignancy. And now we know that TIF1 gamma in adults predisposes to cancer, but in children it does not predispose to cancer. So we know that the cancer risk is not uniform. So how do we determine whether which patient with TIF1 gamma will develop malignancy? So studies have shown that studies have shown.
I just hold on, Hiren. I just want to request everyone to please mute yourself. Except for Hiren, please mute yourself. Thank you.
Okay. Okay, so I'll resume. So we know that the risk of cancer is not uniform across all TIF1 gamma. So is there a way that we can predict out of which TIF1 gamma positive patient who will develop malignancy. So the studies have shown that TIF1 gamma levels above a certain level, that is more than 44 units, are associated with malignancy, whereas a level less than that are less associated. And same goes for survival. So we should also do a titer for TIF1 gamma positive patient to further ascertain the risk of malignancy. And we know that IgG is of 4 isotypes from G1 to G4. They have shown that G2 is the most notorious for associated malignancy. So as we can see on the figure on right, so if there is IgG2 titers are more than 385, the chances of developing a malignancy is 100%. So a positive predictive value of IgG2 levels more than 385 of having malignancy is 100%. And same goes for survival. So whenever there are IgG2 levels are high, there is associated malignancy and reduced survival. And TIF1, why do children with TIF1 gamma do not develop malignancy, whereas adults do? So the answer is in the isotype and the genotype. So isotype, children basically with juvenile dermatomyositis have IgG4 type. And we know that IgG2 is associated with malignancy, whereas IgG4 is not. And then the second point is genotype. So the genotype association in children and adults is different. So that's why the risk in children of malignancy is not known. And secondly, there are certain associated antibodies have been described, like CCAR1 and SP4, which are associated with TIF1 gamma. And whenever they are associated with TIF1 gamma, the risk of malignancy is reduced. So in isolated TIF1 gamma, high risk of malignancy. Whereas certain associated antibodies like CCAR1 and SP4, the risk of malignancy goes lower. So I'd like to conclude my case and with the messages. So adult onset dermatomyositis with rapid progression and refractory course is often paraneoplastic. Cutaneous necrosis, leukocytoclastic vasculitis, and dysphagia. These are the important risk factors for malignancy. And talking about the serological risk factors, TIF1 gamma and NXP2 are the risk factors. Ovoidal palatal patch is associated with TIF1 gamma dermatomyositis and serves as a clue to underlying malignancy. Lastly, detailed characterization of TIF1 gamma, like titer, isotype, and titer, isotype, and this helps in further stratifying the malignancy risk. Thank you.